So I'm glad to have been invited for this presentation for you. I would like to talk about newborn screening. And I would like to start with an overview and then show you some examples of the homocystinuria and remethylation defects in terms of newborn screening. And I would just stick to 3 examples just to make things easier for you to follow. First of all, I would like to define some very important terms when it comes to newborn screening. What is a screening test? A screening test in terms of newborn screening is a lab test which aims at identifying patients before they become sick, which means it gives us the opportunity to take some preventive measures and to help the patients not to develop symptoms of their disease. And this test should be good, must be a very good test. If it's sensitive, this says that it correctly identifies sick people, which means that we don't miss many patients. On the other hand, the test has to be specific, which means it must also identify correctly healthy people. Because if we identify many healthy people and say, well, you have a severe disease, you have to be tested, you have to see a physician, this would cause worries without any benefit for patients, and it would also raise costs. So this is what we need. We need a good test which is sensitive and which is specific for the disease. In the late 60s, there have been criteria written down, and this is about the age of all our screening programs in the middle of Europe. In Austria, we have more than 50 years. The same is true for Switzerland. And these criteria are still true, and we can still work with them just to sort out which disease would be good to screen for. The first condition is that the disease must be important. And this is, the importance is to be seen on a national frame or on a regional frame. It must be important for your population. That means, besides being a severe disease, you will not want to screen for a mild disorder. It must be of a relevant frequency in your population, in your country. The second condition is, and we just talked about this shortly, is you need a suitable and acceptable test. If the screening test is bone marrow aspiration, people will not tolerate that. So it must be not too invasive, it must be easy, and it must be, as you already heard, sensitive and specific for the disease. Then a very, very difficult point is the policy, who's a patient? If we identify by our newborn screening program many people with very mild forms of disorders, what do we tell them? Do we tell you, well, yes, you're born now, but when you're 50, you have a good chance to have a severe myopathy? Do we want this? Does the person want to know this? So we must agree before we start screening programs, who is a patient and whom are we going to treat as a patient? And then, if we have no treatment, screening doesn't make very much sense. And in the best of all cases, the treatment should be effective or more effective when applied early. And it must be feasible. It cannot be too complicated or just to stress systems more than it's bearable for a community. And that leads me to those 2 conditions related to what we have. How rich we are. Can we afford this screening? Can we afford to identify patients and to treat them? And do we have the facilities available? If we have no facilities in our country, it doesn't make much sense to screen and say, well, you have the disease, but we cannot help you. And although this is a very comprehensive and very intelligent single set of criteria, we have variable strategies delineated from those criteria. And I can just illustrate this with a very simple example. It's the 2 countries I'm working in, and the newborn screening panel in Austria covers 31 diseases, and in our neighboring country, Switzerland, which is different but not on a genetic basis, it's so very different from Austria, it only screens for 9 diseases. So screening is not only related to medical facts, it's also related to the background, to the culture, and to the policies of a country. I would like to show you 3 examples for newborn screening in the homocystinurias, and we already heard Andrew talk about that, and I would just lead you very quickly. And just, I'm a clinician, so it's simple. Clinicians always don't like biochemical pathways, and make them simple just to understand them. And so I will share the very understandable version with you. You have already encountered this enzyme. This is CBS. This is the enzyme defect that causes classical homocystinuria. And of course, if homocysteine can't take that way downstairs, you will have more homocysteine because it's blocked. And in the following, you will have a rise in methionine because homocysteine then tends to go up this way. And so we have those 2 biochemical markers for this disease. Now, if we look at the disease from the perspective of the criteria we just heard before, we have to ask, is this a severe disease? And I think Andrew has already answered that question. It has those 4 organ systems affected. It's the brain, it's the eye, it's the skeleton, and we have the thromboembolic events to fear. And we must say that the severe forms have a significant morbidity. This is a severe disease. We can answer this with yes. Do we have a treatment? Yes, we have. You've already heard that. It's pyridoxine for some patients. It's diet combined with betaine for another subgroup of patients. So yes, we have a treatment, and as you already heard, you have a normal cognitive and physical development in patients detected by newborn screening, and so we even have the advantage that early treatment allows prevention of the disease or of disease symptoms. So this is, so to speak, an ideal disorder for screening. But now we come to the tests, and then it becomes a bit more problematic. As you already heard, high methionine is not very sensitive and not very specific, which means you can miss a lot of patients and you trouble a lot of healthy people. So we have to combine this with another parameter. If we think about total homocysteine, which is maybe more sensitive and more specific, if we use it alone, this will cost us a lot of money. And it has high technical requirements, so this is not an easy test. So we can't do that as a first-line testing. But if you would choose a combined strategy and just lower your cutoff for methionine so that you really catch most of the patients you want to catch, but have a reasonable number of false positives in this part, then you can add on with measuring homocysteine in the same blood spot, and you might better identify the patients. But this is a proposal, and this is a promising strategy, and we don't know about sensitivity and specificity of this approach, but we should try it, probably. I would like to move on to another example. This is MTHFR deficiency. And I don't know whether you've encountered that disease or whether there are any patients around with that disease. As you see, the block is here, and due to the interconnection between those 2 pathways, you have a functional block of this reaction. So, in the following, homocysteine can't go upwards to be remethylated to methionine, and so it goes up, and methionine will be low or low normal. So, have we any arguments from a clinical point of view to screen for MTHFR deficiency? Yes, we have. It's a severe disease. Many children die from the disease in their early days. You have developmental and cognitive problems, so it's again a brain disease, neurological symptoms, psychiatric symptoms, and you have the risk of fatal thromboembolism. Do we have a treatment? Yes, we have a treatment. It's betaine, and you have already encountered that drug before. In this case, we have only the advantages of this drug because we can lower homocysteine with it, and we can increase methionine, which is nice to have in this disorder where methionine is usually low. And what has been shown quite recently is that early betaine treatment results in better survival and in normal psychomotor development. So we again have the advantage of a treatment which is better if applied earlier. So this would again be an ideal disorder for screening, but now we have to look for low methionine. And as you may know, it's not easy to spot something that's missing or that's very low. If you have a huge amount of something swimming around in your blood, you will probably find it. But spotting something that's missing is not easy. And some labs even have no lower cutoff for methionine. So if we take, again, a stepwise approach and look for low methionine, which can also be caused by other disturbances of the metabolism or by problems with nutrition, then if you combine it again with a high total homocysteine in the same blood spot, you again have a promising strategy, but we don't know exactly how good it will work because it has not been tried in large samples or at a large scale. The third example is cobalamin C deficiency or cobalamin C defect, and this is a complicated disorder. The block is again here, and you remember from what I showed you before that homocysteine must be high and methionine must be low if the block is here. But you have an additional feature. You also have in cobalamin C defect, you also have a perturbation of the catabolism of a specific acid, which is called methylmalonic acid, and you will find huge amounts of that in your blood and in the urine. So this is a combination of two problems. Again, clinical arguments. It is a very severe disease. Many children die. They have severe eye disease, which may result even in blindness. They have neurological symptoms. They have developmental problems. And so, yes, we have a significant morbidity. Is treatment available? Yes, there is. We give hydroxycobalamin in high doses and we give betaine. But here we have not the ideal disorder for newborn screening, but a good disorder for newborn screening. Early treatment will only result in partial response because we see that patients have improved survival. We see less patients dying, and we have less renal and other organ complications, but the eye symptoms and the developmental problems are mostly ongoing. So we only see a partial response. This is different to what I showed you before in the circumstance of the other disorders. So what can we do for screening here? We have, again, to do a combined strategy. We can go again for low methionine, but I explained to you before that this is difficult to go. But we can go for some metabolites which are related to this problem, to the methylmalonic acid catabolism. And here we have some indicators for that, and we could screen for those. And we could again combine it with high total homocysteine, but we do not have very much experience with that. This is again a promising strategy, but we don't know too much. There have been some approaches, but we don't have a huge amount of data on that. I would like to sum up with the evidence for newborn screening. We've heard disease load is significant, yes, for all three examples. We have treatment, yes, we have, or we have at least a partial response in cobalamin C deficiency. And we have good tests, well, not really. We have promising strategies, but we have more data and more evidence is highly needed. Do we have an agreed policy on whom to treat as patients? Well, kind of. But not perfect. We are not perfect at the point. But we have to set those medical data into the relation to what our health authorities, what our countries want to support. And we have to answer to our local authorities, is that an important health problem? Do we have many children affected by this disorder? And we have to answer that. We have to answer whether we have the facilities to treat those children and whether we can pay for it. So you have to always, when it comes to newborn screening, to have to see the whole picture, the whole mosaic. And we only give the building stones, and the national strategies will be very different. And this is what you've seen with the comparison between Switzerland and Austria. People come to very different conclusions. And you can see this here. You see, this is Spain. This is all data from Spain. And we just sampled this with a simple survey. And you see that Spain has a regional approach. So it's in every region you have a different panel for newborn screening, and they find that those disorders are to most regions are important because they have many patients. It's slightly different for Italy, where we have a more homogeneous picture. We have the Irish experience. They screen for CBS deficiency only because they have many patients with CBS deficiency. And then we have some countries, including Switzerland and including Austria as well, where none of the diseases is screened for because we don't have many patients. But this can be changed in the future if tests get better and we identify more patients. But this must be considered that this is always the background for newborn screening. Future prospects. I just, took the liberty to mark some jobs for you and for us. So you are in red. I think what we need is more than what we have of expert cooperation. I learned a lot when I came in touch with all the colleagues in the EHOD consortium, and that was, it was good, and we had a good exchange, and I think we all learned from each other. But we need your help, I think, in the promotion and in the support of this cooperation. We have established a registry, Henk alluded to that before, but we need you to participate. I cannot really understand patients not giving their consent for participation because we need data to do better work for you. And we need, and I think that's most important, we need to pool your data. And we need to define meaningful outcome parameters. What do you want us to target with our treatments? Do you want that we only target biochemical measures? Do you want us to target quality of life? Whatever. So help us by giving us more information on the parameters which really are meaningful for you. What we have to do is to pool the newborn screening experience. There's this very good example from the US where large data has been sampled on newborn screening, and we have been in cooperation with those people, and we have to develop standardized approaches and procedures so that we can compare and share our data and say, well, this strategy works and this doesn't work. This, if we can do our jobs very properly, this might improve our understanding of the natural cause which we need to make decisions on newborn screening, and might help us better to understand treatment effects. And if we develop guidelines, as Andrew already alluded to, this will standardize procedures, this will standardize treatment, and this will standardize follow-up, and therefore generate standardized data sets. If we have guidelines, we are easier to cooperate with other centers, and we can then collect a substantial body of evidence so that I don't have to tell you next year or in 2 years' time that we don't know very much about sensitivity or specificity of our approaches. Thank you for your attention.